In the name of God, the most gracious, most merciful, under the auspices of the President of University of Kufa, Dr. Yasser Al-Aqali, and Dean of College of Medicine, Professor Dr. Raed Amran, and participation of Assistant Prof. Dr. Ali Hassoun from University of Alabama, and consultant Dr. Zahra Chaudhry from Huntsville Hospital, USA, hold the international webinar COVID-19 vaccine update. Welcoming speech to Professor Dr. Raed Amran, please.
Thank you very much, Professor Abdul Amir. بسم الله الرحمن الرحيم الحمد لله رب العالمين اللهم صل على محمد وآله الطيبين الطاهرين. Our esteemed guest, our distinguished guest and speaker was this evening discussing the most hot topic over the world, the COVID-19 vaccination. So welcome all of you, and we can start Dr. Abdul Amir with our speakers, please.
Yes, thank you, Dr. Raed. First topic, COVID-19 vaccine types and results for Dr. Ali Hassoun. Dr. Ali Hassoun, Assistant Prof. And Specialist in Infectious Disease and HIV Specialist, University of Alabama, USA. He is a specialist in infectious disease and HIV in Alabama Infectious Disease and HIV Center in Huntsville Hospital, Alabama. Dr. Hassoun certified by American Board of Infectious Disease and Internal Medicine. Also, he is reviewer for the Journal of Hospital Pharmacy, International Journal of Infectious Disease, and PMJ Group. He published many articles and authored book chapters. Also, veteran researchers with special interest in Clostridia difficile, MRSA, MDR organism, COVID-19, and infection control prevention. He is Infection Control Director for Area Hospital and lead the COVID-19 Task Force Clinical Management Team for Huntsville Health System. Dr. Ali, please, the stage is yours.
شكرا جزيلا. السلام عليكم. Thank you so much. تقبل جميع صيامكم وأعمالكم وقيامكم إن شاء الله. So today what I'll do, I'm going to share my screen. Can you let me share my screen? Dr. Abdul Amir is saying disabled. Yeah, there you go. Yes. So today what I'll do actually, I'll talk about the different mechanism of COVID-19 vaccine, the different types available, as well as the efficacy and safety data about COVID-19 vaccine. You know, after that, I will present some of the phase 4 data about what we have in the United States and what information available about the efficacy and safety about COVID-19. So to start with, really what's very important to get with the vaccine is understanding the coronavirus structure. And the most important part of that, you know, as you know, SARS-CoV-2 is a single-stranded RNA enveloped virus, but the most important structure that we pay attention to is what we call the spike protein. The spike protein is the main side where the virus enters the host cell, including the respiratory tract. And because of that, the immune response of the virus against the virus actually will be to that specific spike protein. And vaccine development been made mainly around that of developing immunity or vaccination against that specific structure. So there's a lot of different vaccine which I'm going to mention initially with mechanism, and then we'll go on the efficacy and safety. So the first one is the mRNA vaccine. And the ones that have been available around the world, specifically still in the United States as well, is Pfizer as well as Moderna vaccine. And the mRNA vaccine concept is really you make a genetically engineered sequence of an RNA where you can deliver it to the cell. And when you deliver it to the cell, it's going to encode that specific spike protein in the human being. And I'll show you a diagram of what that means and how it works. Usually that specifically genetically engineered sequence will be enveloped in what we call a lipid nanoparticle, just to protect it from being destroyed by the cell, and it make it easier to get into the human cell as well. Very important to know, the mRNA is not replicating, it's just you deliver it and will induce that response. So both these mRNA vaccine is given intramuscular, and all the vaccine available currently, all different type given intramuscular. For the mRNA vaccine, when it given intramuscular, it mainly really stayed into the muscle there and it spread to the lymph node, where it can induce immune reaction. So for Moderna, usually it's given 4 weeks apart. For Pfizer, it's given 3 weeks apart. What's important to know, at the moment, we don't have enough information to interchange these mRNA vaccine, even though they are the same type of vaccine. So as that mRNA get into the cell, it will initiate the ribosome to make that spike protein. And if you see it here, for example, it will initiate that, and the ribosome will initiate that spike protein. The spike protein will be made, and it comes to the surface of the cell. And as it comes to the surface of the cell, there's going to be an immune response, that including a T cell, a B cell response, and antibody response, including immunoglobulin, IgG, and IgM, specific for the spike protein. And that's how we develop that immune response. And this is for Moderna or Pfizer, the way we do that. What about the viral vector vaccine? The viral vector vaccine, just a little bit different in the way of delivery of that message. And currently what we have in the viral vector vaccine is the AstraZeneca vaccine, as well as the Johnson & Johnson vaccine. And what happened actually, you use a incompetent virus. And in this case, what they're using, the adenovirus. The incompetent non-replicant virus, they put in it a gene that encodes for the spike protein. So when you introduce the virus into the human cell, it's going to incorporate and then start inducing the production of messenger RNA and producing through the ribosome a spike protein. And as it do that, it's going to induce immune response, like we talked about how the mRNA do. And again, the example is AstraZeneca. And AstraZeneca, difference from the Johnson & Johnson, they use the chimpanzee adenovirus. And compared to Johnson & Johnson, they use a human adenovirus. The idea of using chimpanzee adenovirus is avoid previous history of exposure and immune response. If the human have been exposed to a regular human adenovirus, they might make a response to that. Of course, that's theoretical and hypothetical. It really hasn't proved fully into that aspect. The other type of vaccine is the inactivated virus or attenuated virus. And currently, the inactivated virus that's available is the Sinopharm or CureVac virus that's produced through the Chinese laboratory institute. And of course, you know, the Sinopharm that's available, it goes into the way of similar mechanism that we have on other viruses, where you introduce an inactivated virus and your body will respond to it in different immune mechanism in there. The last one is really the protein-based vaccine. And the protein-based vaccine, actually you take the spike protein from an inactivated COVID virus or killed virus, and then surrounded by a nanoparticle of lipid to protect it and introduce it into the human cell. And after that, as the human cell get exposed to that specific protein, actually you can produce that immune response. And Novavax, Sanofi, actually GSK, has been studying this, and there's some data on that. Not a lot, but actually they're working on it. Before I talk about the efficacy and safety, there's always been discussion about, well, this vaccine has been made within short period of time. We're concerned there is really no long-term effect. It was done hastily. It was done pretty fast, and we worried it might be an issue with that. So if you look at the top part, when we look at the traditional vaccines, the traditional vaccine made, for example, in over 10 to 15 years. In the accelerated vaccine development, which is the lower part, what they've done, because it's a pandemic, you can actually stack and make several phases in parallel at the same time. So you can do phase 1 and phase 2 at the same time as you check for safety, as well as the preclinical data. And as you get result, you move on to phase 3 and you start manufacturing at the same time. So that's why we were able to get it within a year period of time. But every step that need to be followed for studies of a vaccination, it was followed, no cut corners. There was no issues of, let's shorten period. No, everything done in the right way to make sure safety and efficacy is done the right way and studied the right way. As well as following in safety, any vaccine, to look at their safety, you need really maximum 2 to 4 months to know about it. There is no long-term effect later on more than that. So there's no such thing as a year or two later, there's something come up with a vaccine effect. And 2 to 3 months already been done and gone through most of these vaccines. So what about the data? So if you look at the Pfizer data, they enrolled about 45,000, of course, half in the placebo and half in the active stage. And if you look at for efficacy, for symptomatic disease, 95% efficacy. For hospitalization, it's 100% efficacy. That prevented hospitalization. And there was no death in the group. For safety-wise, for serious adverse events, there was comparable to the placebo. And for severe reaction, it was higher in the vaccine versus the placebo, but it was the expected reactions. Local reaction like pain and swelling, systemic reaction like fever, ache, myalgia, that comes within 1 to 2 days and resolve on average within 24 to 72 hours. What about the Moderna vaccine? It's the same story. For efficacy, they enrolled about 30,000. Symptomatic efficacy, about 94%. For hospitalization, about 89%. And there was no death in the active group who have or received the 2 doses of Moderna vaccine. Safety, there was no serious adverse event. For severe reaction, again, some higher, but it was as expected. If you look at the phase 4 data for Pfizer and Moderna, the most common reported was headache, fatigue, dizziness, fever, chills, nausea. And if you look at the range, up to 20% might be a little bit higher, but there was nothing unexpected in these 2 type of mRNA vaccine that showed or concerning. There was initial concern about possible anaphylaxis that's coming up. And if you look at, as they studied, there was a 5 per million doses in the Pfizer vaccine, and there was about 2.8 per million doses in the Moderna vaccine. And this is usual like what placebo or general population can develop. So it was not concerning there. Moving from the mRNA vaccine, now the AstraZeneca vaccine in J&J. And we'll talk first about AstraZeneca vaccine. So they actually enrolled, even though it's saying 23 active participants, they enrolled at the end up to about 33,000 in their study. As efficacy, it was a pooled analysis with efficacy of about 70% preventing symptomatic COVID-19. And actually, there was no hospitalization, no severe disease in those who received the active vaccination part, which is 2 shots. And I'm going to tell you, initially they did it differently, but now the conclusion of how we recommend AstraZeneca given. So initially they analyzed it in the standard dose, but that they found at one point, some of their patients received in the first dose at low dose, and then later on a standard dose. And surprisingly, actually in the low dose than standard dose, the efficacy was much, much higher, about 90%, in compared to the standard dose, about 60%. Also, what they found, instead of giving it 3 weeks apart or 4 weeks apart, they found if you give it 12 weeks apart, you're going to have a better immune response. And if you look at it, if you're done more than 12 weeks apart at the lower part of the table, you actually have much higher spike antibody response. And the same goes for efficacy at the same time, 81% versus those who got it less than 12 weeks, it was about 72%. Safety-wise, it was safe, mainly the headache, the pain, the swelling, the redness, but there was report of transverse myelitis initially. 1 case in the active arm, and then in the placebo arm, actually later on there was report. So as they analyze it, they found no difference, and there's no concern about transverse myelitis there. So safety-wise, again, it was as expected, and less than 1% of their population developed in the active study that. And then comes within 4 weeks of introducing this, they found there's cases of thrombosis. In Europe, there was about 169 cases of cerebral vein sinus thrombosis, and then 53 cases of splanchnic vein thrombosis. If you look at the rate, because they gave about 34 million, and the rate is about 10 cases per million. So that's very, very low. So they still not sure it's completely connected, but they put a warning about it that it's possible. In the UK, they had about 168 cases, and the rate was 7.9 million. The majority happened after the first dose. There was some positive anti-heparin inhibitor factors there, but again, they were not sure 100%, but the majority happened in younger age, between 18 to 49. And if you look at the end, the UK came and said, well, everybody above 30 should get AstraZeneca. Below 30, you can provide alternative. And that's depending on this table, looking at risk factors for the thrombosis and risk from dying or admission to the hospital. And if you look at 20 to 29-year-old, the risk of admission, ICU admission 2.2, but it was 1.1 for thrombosis. As you go down above 30, the risk is much lower in thrombosis in compared to the risk of ICU admission and severe. That's why they decided above 30, everybody should get it. And that brings us to the Johnson & Johnson. In the Johnson & Johnson efficacy, in the symptomatic 66%, hospitalization 93%, and safety-wise, no serious adverse event, severe reaction, a little bit higher with local reaction, fever. And then again, there was some signal about thrombosis, but it was much less than what AstraZeneca even had. And if you look at AstraZeneca in the J&J, in the age of 18 to 49, it was 7 per million, because only 15 cases reported in 7.98 million vaccine given. And then it was less than 1 in 50 and plus. The majority happened in 30 to 39 in that group. And again, actually, the CDC came back and said, Everybody should get the Johnson & Johnson because the benefit outweighs the risk. Because if you imagine you give it to 18-year-old and above, the risk of ICU admission and death is much, much higher in compared to only 1.9 per million of thrombosis. And a reminder, oral contraceptive associated cerebral vein thrombosis is much higher, about 130-time-fold increase. Pregnancy is much higher. COVID-19 as a disease is associated with much higher risk of thrombosis. Few words about the Sinopharm. The Sinopharm, there's really not enough data of phase 3 published. There's phase 1 and phase 2 data saying there is some benefit. Most recent one said 1 dose is about 16 to 20%. After 2 doses is about 50 to 60%, might be a little bit higher. But there's really no good enough safety data about it. And that brings us to the concern about there's more variant coming in. What are we going to do about it? Is the vaccine effective or not? And the most common variant is the one originally described in the UK, then one in South Africa, and one in Brazil. And most of the data showing the vaccine is still effective that we have with the mutations there. And that's very important because, especially with 2 doses, it's continued to be effective, even though the number of antibody response might be lower, but the response and efficacy maintained there. Contraindication to the vaccine, for Moderna and Pfizer, the polyethylene glycol part, if you're allergic to it, you shouldn't get it, otherwise shouldn't be an issue. J&J is the polysorbate, the same in AstraZeneca. We usually, if you're sick with acute illness in any form, better to avoid the vaccine. If you've been sick with COVID-19, wait 6 to 8 weeks. If you receive convalescent plasma or the monoclonal antibody, wait 90 days. If you're allergic to any other type of vaccine, usually you can get it, but you better talk with your primary care doctor in there. We usually try to avoid vaccination at the same time. So if you had the flu shot, wait 14 days there and there. And then we don't know yet about data about can we mix. There's actually countries mixing it, but we don't have published data about it. And I'll end with the phase 4 data that we have from the US. There's about 220 million doses given of Pfizer, Moderna, and J&J. The most important part of this, the initial concentration was on healthcare professional as well as elderly. And now we open it up to 18-year-old and above. And if you look at above 65, already in the United States, 81% received at least 1 dose. And 2 doses, they had 67%. And that's very important. We reach almost at least 1 dose, 50% of the population received that. And the CDC published this of a breakthrough infection. Imagine 75 million got full doses and only 396 get hospitalized with COVID. That's like a 0.00060 zeros in there. The efficacy is there of the vaccine. The same if you look at it in healthcare professional. If they did not receive, you look at the top graph in the bars, if they receive no vaccination, they continue to have significant rate of infection. If they have 1 dose, the rate will go down. If they have 2 doses, the rate go almost to 0. The same in the hospital who get the vaccination with good higher rate, actually the rate of testing and infection goes down significantly. And the same goes as the days go by from your day of vaccination, your chances of infection will go down. Look at the table in the second column. If you day 1/7 after the first dose, it's 145. But as you go down, day 15 after a second dose, the rate of infection went down significantly if you're fully vaccinated. The rate of cases in the United States went down significantly over a month period of time. Now, the cases of death went down significantly. The elderly incidence rates of infection, this is the lower part, 65 and above, went down significantly and is going down for the others. And hospitalization, if you look at the top graph in red, This is elderly 65 and above went down significantly as well. And to end with this is a country with the most vaccination in 5 elements of COVID-19 as an incidence, as a cases, as hospitalization, as severe disease, as ICU admission and death. If you look at the orange graph, is those not vaccinated, those with the blue is vaccinated, and in every element, it actually everything went down. So that shows vaccination is very effective as well as safe. And I'll end with this. Thank you so much.
Thank you very much, Dr. Hassoun, for this precious information. For the participant, the questions about each session will be opened at the end of the sessions. Now, the second topic for consultant, Dr. Zohra, and the topic, why COVID-19 vaccine effectiveness in pregnancy, lactation, and chronic disease. Dr. Zohra Chaudhry, she is consultant infectious disease at Huntsville Hospital, USA, graduated from University of Cambridge and University of London, early medical training in Lahore, Pakistan, joined Division of Pulmonary and Critical Care at Emory University School of Medicine. She has a 3 years internship and residency in internal medicine in Wellstar Atlanta Medical Center, joined infectious disease at Henry Ford Health System, Wayne State College of Medicine, Michigan. Also served as a chief of medical fellow during her final year of infectious disease fellowship. Dr. Chaudhry is board certificate in internal medicine and infectious disease, Society of America, also HIV member association, American Society of Microbiology, American Society of Transplant, and Society of Healthcare Epidemiology. Currently working at Huntsville Hospital as infectious disease consultant and particular interest in infection of transplant and immunocompromised patients. Dr. Chaudhry, you can start now.
Should probably muted.
Dr. Chaudhry, I think it's muted on your side. You can unmute.
Okay, sorry, I don't know why I wasn't able to unmute on my own. So I'm going to start hi everyone. Thank you so much for giving me the opportunity to talk today. I'm Dr. Zohra Chaudhry. Assalamu alaikum. So can everybody see my screen with my presentation?
Yes, you can go on. It's very clear, sound and screen.
Okay, yeah. So the topic that I'm going to be talking about today is COVID-19 vaccine. Why do we need it? I'm just going to touch briefly on the effectiveness and then COVID-19 vaccine in certain special populations. So as we all know that COVID-19 presented us with an unprecedented challenge that has threatened the health of people all over the world. Since WHO declared it as a pandemic around 11th March last year, more than 3 million people have died all over the world. And, you know, we have more than 147 million confirmed cases, and the number continues to go up by the day. So due to its impact worldwide and the lack of herd immunity, given that it is a novel and a new virus, governments all over the world have been forced to implement harsh restrictions to curb the spread of the virus. So before I jump into, you know, why we need COVID vaccine, I wanted to briefly talk about herd immunity, because to understand herd immunity is important to get the concept of why vaccines are important. So herd immunity is also known as community immunity, and it occurs when a high percentage of community population becomes immune to the disease, which makes the spread from the person to another person unlikely or less likely. So this schematic just shows the The person in orange is a disease carrier. Everyone in blue is susceptible when you don't have any immunity. But when you have vaccinated or immune individuals, then the people who are susceptible of getting the infection, the number goes down significantly, and so does the chance of getting the infection in the community or spreading it goes down as well. So how herd immunity is achieved, that happens through two ways. It can either happen that you get an infection, you recover from it, or you have to be vaccinated. So depending on the infectivity or contagiousness of the disease depends on how soon you will develop herd immunity. So for a virus like COVID-19, which is highly contagious, so you need roughly around 70% of population or even up to 90% to call it immune. So this will reduce the risk of getting COVID-19, but it does not prevent it for non-immune people. So to get it through being naturally infected, you also have to survive the disease. So this naturally comes with the risk of increased mortality, people die, morbidity, which is, all the side effects that we're seeing in people who are survivors from COVID-19, and then it carries the risk of overwhelming our healthcare system, which we have seen in countries where vaccines have been delayed and we have so much hospitalizations and mortality, and the healthcare system is just not able to cope with that. If you try to create herd immunity through vaccination, so then people can develop immunity to that disease without actually contracting the disease, and that can break the chain of infection, and it won't give you all the undesirable issues you get from getting the infection itself. And this way you also confer immunity to your vulnerable population, such as newborns or certain immunocompromised people, even though they themselves cannot get vaccinated. So, so if you just look at natural herd immunity, if we take the level, if we take 67% or 70% of population to be immune to develop herd immunity, and your mortality is 0.6%, so you still have like more than 30 million people who are dying worldwide to bring that level up for herd immunity. But COVID-19 vaccination, it provides a way out of this pandemic without losing so many lives, without depleting our resources, and without overburdening our healthcare system. And it also prevents SARS-CoV-2 from continuing to mutate, and then our variants mutation goes down, and hence it won't become as resistant. So Dr. Hassoun did talk about this COVID-19 vaccine. We have RNA-based vaccines, we have viral vector vaccines, we have protein adjuvant inactivated viruses, and all have pretty good effectiveness that was demonstrated in their phase 2, phase 3 trials. So this is just, looking at all of the Pfizer, Moderna, J&J, the most common vaccines. So if you look at, how many are going to prevent against severe COVID. Pfizer and Moderna, 100%, J&J, AstraZeneca, also 100%. But if you look at variants, almost all protect against your Britain variant, which is B117. A lot of the viruses have reduced immunity against your B1351, which is a South African variant. And this is important if you know what variants are important or more prevalent in your community. And then J&J and Sinovac also have reduced effectiveness against your Brazil variant. So nowadays we all know about the Indian variant, the triple mutant, but so India has its own vaccine, Covaxin, which has shown to produce neutralizing antibody against the Indian variant as well, and across all other variants. So COVID-19 vaccine, if you look at, so there is always the experimental data, what we see in trials. So if you want to look at what's actually happening in real world, if our trials are saying it's 94 to 95% effective, are we actually seeing that in our real life as well? So there have been a few studies that have been published. There was a small CDC study that looked at about 4,000 healthcare providers, which includes first frontline responders, essential workers, which received mRNA like Pfizer or Moderna vaccine. So it was 90% effective at least 14 days after the second dose. Then most recently, there was a trial which was published by Mayo Clinic where they administered 94,000 mRNA doses to about 49,000 of their employees. And they looked at the efficacy, and 96% efficacy was reported. Similarly, European studies have been reported where they've been using AstraZeneca and some Pfizer vaccine, and they've noted that their COVID rates, COVID-19 new infections are going down, hospitalizations are going down, mortality is going down, and they're also, against the classic COVID-19 variant and also the B117 UK strain, which tells us that these vaccines are also working in real life and controlling and curbing the spread of COVID-19. So this is just a schematic showing projections. So with mRNA vaccines, so in people who are fully immunized, and fully immunized starts from 14 days after getting your second dose of the mRNA vaccine. So you see that your hospitalizations are pretty flat. So you're not really getting hospitalized. If you're partially immunized, you can still have some hospitalizations, but if you compare it to non-immunized, you can still see the remarkable difference. And that's important in letting people know, especially with the vaccine hesitancy, that vaccines do work. You may be able to get COVID, but it still reduces the chances of hospitalization and your chances of dying. So now coming to specific populations. So first is pregnancy and lactation. So we do know that pregnant females are especially prone to having severe COVID complications. They're more likely to be admitted to the ICU, more likely to have a severe infection, increased risk of preterm birth, or even having preeclampsia or eclampsia. So given the vaccines that are available or recommended in COVID-19, so there are the mRNA vaccines, which is a newer technology, and you have the Johnson & Johnson AstraZeneca. So the type of technology that J&J and AstraZeneca use is a viral vector, which has been present for a while now. And this is what was used in the Ebola vaccine as well. And just looking at, if you want to extrapolate data from the older trials, no pregnancy-related adverse outcomes were reported, including in the infant. And just coming back to mRNA vaccine and pregnancy and lactation, so there have been studies which have demonstrated robust humoral immunity in this subset. Non-pregnant females and pregnant females have comparable immunogenicity and reactogenicity with the vaccine, and your responses from the vaccine are significantly greater as compared to if you were to get just the infection, so natural immunity. And you can have immune transfer to neonates, which occurs via placenta and breast milk. So even though we have limited data in pregnant or lactating women, and there is certainly no evidence that is linking any vaccine to fertility issue so far. And we know that there were people in trials who became pregnant when they got the vaccines, and we know that they're being actively monitored by the respective vaccine manufacturers, and no adverse events have been reported in those individuals so far. We have animal studies which have found no safety concern before or during pregnancy with these mRNA COVID vaccine. So the recommendation so far is that it is okay for pregnant women or breastfeeding women to get the vaccine. Then the next population is your solid organ transplant recipients. So prevalence and mortality of COVID-19 is higher in solid organ transplant recipients. They're also at a higher risk for adverse outcomes. We don't know the efficacy of vaccines in this particular population, but we do know that these vaccines are not a live virus. So these are all different technologies, but at least they're not living viruses like MMR. So they are okay to be given in solid organ transplant recipients. But now if you come to the efficacy, so that we still don't know. There have been some reports, so after just getting the one dose of mRNA vaccine like Pfizer or Moderna, you only have 11 to 17% anti-spike antibody levels if you check them after 20 to 28 days. This level may go up after second dose, but we still don't know how much it will go up, or how significant is this immunity going to be. But so far, it is still recommended that these people get vaccinated. If you're going to vaccinate in a pre-transplant person who's undergoing workup, they're going to be transplanted, you should try to give them their vaccine and have them finish the vaccine 1 to 2 weeks prior to transplant. In the immediate post-transplant phase, when they're going to be getting their induction immunosuppression, then you can hold off on the vaccine. But when they're on their stable immunosuppression, then they are okay to receive the COVID-19 vaccine. Then your stem cell transplants and CAR T-cell recipients, similarly, they are also at higher risk for COVID-19 complications. If they're going to be getting an allogenic or autologous transplant, then the vaccine should be delayed at least 30 days prior to getting the transplant. So that's when we know it will best work for them. But if they've already gotten the transplant, then it is best that you delay it 90 days after the allogenic transplant and 30 days after the autologous transplant and CAR T-cell therapy. So just looking at malignancy, and this includes both hematologic malignancy and your solid organ tumors. So in those, anybody who's on active chemo and you think they're going to be finishing their chemo in the next few months, you can hold off and let them finish the chemotherapy before you give them the COVID-19 vaccine. But if they're going to be on chemo or immunotherapy or small cell molecular therapy for a while, then you can give them COVID-19 vaccine between their chemo rounds. But if they're only on radiation therapy, then they can get the COVID-19 vaccine at any point in time. And autoimmune disorders and HIV. So there is a theoretical risk with autoimmune disorders with mRNA vaccine that it may cause a flare-up of like lupus or rheumatoid arthritis or IBD. But so far, no cases have been reported, and it is just a theoretical risk and very less likely for them to have a flare-up. And it's okay for them to get a COVID-19 vaccine. Even with HIV people, it's okay for them to get a COVID-19 vaccine regardless of their CD4 count. But if you're going to be giving them their other vaccines, then you should space the vaccine, COVID-19 vaccine and other vaccine for about 2 weeks. Then there are certain medications that can suppress your immune systems, especially methotrexate, your lymphoma medication, rituximab, alemtuzumab. So what they do is they suppress your production of neutralizing antibody to the antigen. And based on older data from influenza and pneumococcal vaccine, we know that they will suppress your humoral response, so B cell response and antibody production. And there are no clinical trials which have demonstrated your efficacy in these particular subset of patients to see when they can get the vaccine, if they should get the vaccine. But so far, the recommendation is that if you are going to give them the vaccine, then you should do it 4 weeks prior to initiating their immunosuppressive B cell medications. If you have already started them on therapy, then you can consider delaying the vaccine by 3 months. And if they've already gotten the vaccine and you are going to restart their medication, if it's safe for them, you can have them wait 4 weeks before you give them the vaccine, the second dose, 4 weeks after the second dose of the vaccine. So in summary, what we need to know is that herd immunity via vaccination offers a more safer way out of this pandemic without overburdening our healthcare system and avoiding the deaths and morbidity which follows natural immunity. None of the COVID-19 vaccines are live viruses and they cannot cause COVID-19 infection. Our vulnerable population, including immunocompromised patients and pregnant women, are at especially high risk for adverse outcomes from COVID-19 infection. So vaccine administration should be offered and prioritized in this vulnerable subset when possible. And thank you so much.
Thank you very much, Dr. Chaudhry, for this informations and the clinical conditions query for vaccines. Third topic, COVID-19 vaccine and children, presented by Professor Dr. Raed Amran, Dean of College of Kufa Medical School.
Thank you very much, Professor Abdelamir. Great thanks to our speakers for the nice presentations and a lot of information, and they ask so many questions in our mind about the vaccination types, their efficacies, the results, and in a special population. For now, we need to talk about the vaccination of children with COVID-19. So many people asked they are asked about whether we can vaccinate our children, when we can vaccinate them, what could be the response of the dose, is it the same, they will have a side effects. So we will try in these few minutes elaborate these concerns and try to answer these questions. Children, as we know, children is not just a little adults, so it cannot be just changing the dose or because they are smaller in size. The children, they have their own immune system, and it's different from adults. The exposure of immune system in children is different from that in adults. Adults have a lot of exposure, so they have their immune system exposed to so many antigens that's not present in children. And COVID-19 in children is different in the susceptibility and presentation from adults. Most of children, they have milder presentation, and they are still susceptible to have an infection. And for that, the safety and the precautions around the vaccination should be contained in the studies and research for the vaccination. For that, it's delayed to this time. So do we need to vaccinate our children? Although some of the children presented with severe presentation and what we call multi-system inflammatory syndrome in children, and the mortality was less than 1 in 1,000, but they are still transmit the disease to others because they are mildly presented with the disease or less symptoms than what we have in older ages. Which vaccine? On March 31, Pfizer announced in a phase...
Sorry, Professor Raed, are you having a presentation? Because we are only seeing the number 1 slide. Okay, now it is okay.
Okay, thank you. So on March 31, Pfizer announced in a phase 3 trial of adolescents between the ages of 12 and 15 years old, with or without prior evidence of COVID infection. They announced that 100% effective, and the result exceeded what those show in a trial of 16 to 25 years old age. This trial included more than 2,000 kids distributed in 2 groups, placebo and vaccinated group. The result showed that the vaccine was equally effective at producing an antibody response in younger children as compared to teens and young adults from the earlier trials. Dr. Sabila said that the result from the phase 3 trial will need to be undergo peer review and presented to the FDA for emergency use. It was used in the earlier trials. Pfizer reported that the side effect is consistent with those reported during their earlier trials with 16 to 25 years old age. The 12 to 15 years old age will be able to get vaccinated before the start of next school year. And the company also announced that it has started a global study to evaluate the safety, tolerability, and effectiveness of their COVID-19 vaccine in children between the age of 6 months to 11 years old. So the trial started for such age, and the main goal for the vaccine was to protect children and get pandemic under control, because most of the children don't have significant symptoms, and some children have severe and they show post-COVID-19 multisystemic inflammatory syndrome, but they still transmit the disease. By vaccination, we can protect them and stop the transmission. For school, we did well with the precautions during opening schools. Still, we need to have these precautions. The vaccination will add one step forward to protect our children in their school attendance, and same for their activities, indoor or outdoor activities. Same precautions should also still present even when we will have the vaccination. More trials in progress now with Moderna. And
sorry, Professor Raad, again, the slides are not. Yes, yes. Okay.
So there's more trials from Moderna, and earlier in March, Johnson & Johnson said they start their trials for ages between 12 and 17 years age. And the vaccine, is the vaccine safe for children? So WHO showed that vaccines are usually tested in adults first to avoid exposing our children who are still growing and developing. COVID-19 has also been more serious and dangerous disease among older children. So, since the vaccine shows safety, and as Dr. Ali and Dr. Azora tell us about the safety of the vaccination, the trials started for children. And once those studies have been completed, we will have the guidelines to administer vaccines for our children. In the meantime, we need to make sure that children continue their physical distance in their activities, in their school attendance. They need to clean their hands frequently, sneeze and cough into their elbow, wear a mask if age appropriate, and thank you.
Thank you very much, Dr. Raad, for this information about children and the school period. Now we have many questions from participants. Some of them had already answered during sessions. I filtered 5 questions. Of them still need some explanation. 2 questions for Dr. Hassoun. First one, if IgG not elevated after 1 month of second dose of vaccine, can we use another type of vaccine?
So, you know, one important thing about this, IgG is not the only marker of immune response, because with any vaccination, immune response, including the B cell, the T cell response, as well as antibody there. So currently, from what we have data-wise, we don't recommend adding another dose or a booster dose or a different vaccine, because most of the studies that's done with 2 doses, these patients, even though some of them might not have positive antibody, they still have good immune response there.
Thank you very much. Second question, can we use a second dose for patients receiving first dose of certain vaccine and a second dose for another vaccine?
Yeah, so there is no study published about that. I can tell you, for example, in the United Kingdom, they doing some studies on mixing AstraZeneca and Sputnik vaccine, the Russian vaccine. In Norway, there was a trial just started last week mixing AstraZeneca with Pfizer. Germany have done that, but there is no good, well randomized trial to say it's going to be efficacious or it's going to be okay to do it.
Thank you very much. I have also 3 questions for Dr. Chaudhry. First question, when should give second dose of vaccine if patients get infected a week or more after the first dose?
So if they get infected after getting the first dose of the vaccine, then they should still finish, be treated as somebody who had COVID-19, if they need steroids, if they need remdesivir, all of this. So they should still be treated as any other person who would get COVID-19. And then you have to finish your quarantine period. Still, it's recommended that you can, because after you get natural infection, you can develop antibodies. So you can safely wait up to 90 days before they resume their COVID-19 vaccine series.
Thank you. Second question, regarding AstraZeneca vaccine. Is it contraindicated in cases of cardiovascular disease or CVA patients?
It is not.
It is not. Thank you. Third question, regarding prosthetic valve. Patients with a prosthetic valve or on anticoagulants, can they get the vaccine safely?
Yes, they still can get the vaccine safely.
Thank you. We have a recent question, Dr. Hassoun, regarding safety of types of vaccines, whether short-term and the long-term. Is there enough studies to ensure us about the long-term side effects?
Yeah, and probably you've heard me in the beginning on the in the presentation. I really
Yes.
The discussion about long-term effect of vaccination. If you look at all different vaccines, there's no such thing as long-term effect of a vaccine. If we get any safety issues, safety signal, side effect, if it's gonna happen, it's gonna happen in the first 2 months. Maximum, if we wanna really stretch it, 3 to 4 months. But really, if it's gonna happen, it's gonna happen these 4 to 6 weeks after getting the vaccine. So there is no such thing as a long-term effect. One reason for that, for example, people is worried about the mRNA vaccine, if it gets into the gene and stuff and cause problem. One, the mRNA vaccine, when it get into the muscle and lymph node, it actually within 10 days, it get wasted and taken out completely. It get destroyed. So there's nothing left of that mRNA. It doesn't get into the DNA, so there's nothing get into the genome and that replicate and stay. And the majority, again, if you see it, it's gonna show up if there is any problem. A mean duration is 3 days after the shot. What's interesting about the clot, whether AstraZeneca or Johnson & Johnson, the report happened again within the first 2 weeks after introduction in there. So I don't think we should say there is a long-term effect, because even looking at all different vaccination over the years, there is no such thing after 3-4 months, there is going to be a vaccine effect.
Thank you very much. We have another recent questions regarding the Indian mutation virus. Does these vaccines work to protect against the new mutation, double spikes, Indian virus?
Dr. Chaudhry talked about that, if she's still.
Dr. Chaudhry, if you have information about it.
She probably muted. So I can answer that. You know, you need to unmute her. Sometimes it's hard to, but I can tell you, when you look at the variant, the variant they describe in India, I always be very careful as labeling Indian or Britain or South African, because the reality, these variant, when it got described, they were doing a good job of screening and gene sequencing. That's why they found it in Britain first, for example, or in South Africa first. So the one described from India, the gene mutations, even though it's double or triple, it's a mix of what we know about through the South African and the Brazilian. There is really not yet data specific about the Indian, the origin from the Indian variant, but we know for the United Kingdom originated one, or the South African or the Brazilian is effective. The CDC at the moment, actually, they had a few days ago, meeting concerning that, and they thought the current vaccine, and they're talking about Pfizer, Moderna, those you get 2 doses, and AstraZeneca, should be still effective against that. And reminder, unfortunately in India, the rate of vaccination remained to be about 10% and less. And I think that's the main issue happening. Not much vaccination, you're going to have spread of the virus there.
Thank you very much. I see we have answered most or all of the questions of our participants. So at the end of our webinar, we thank you very much for your participation and your great information, Dr. Hassoun, Dr. Chaudhry. It was a very nice time to hear for these updates. We hope to repeat it as soon as possible. Final word for Professor Dr. Raed, if he likes.
Thank you very much, Professor Abdelamir. I would like to thank our guest speakers, Dr. Ali Hassoun, Dr. Chaudhry, for their time to be with us, for the nice presentations, a lot of information, and Dr. Ali always with us. Thank you so very much for your cooperation, and we hope that we will meet again, and including Dr. Zuhra with the new webinar and another topic, inshallah, in near future. Thank you so very much for our guests, for our attendees, and a special thanks for Dr. Falah and Dr. Abdelamir who arranged for this webinar, and we have a very nice time with all of you. Thank you so very much.
Thank you very much, everybody. Goodbye. God bless you.
Thank you so much, everyone.
Thank you, Dr. Azhar.